Welcome to EMT Refresher Module 1. This module we're going to be covering airway, neurological management, EMS research, and evidence-based medicine. Objectives for this module is going to include discussing and describing the ventilatory process, being able to identify adequate versus inadequate breathing, ventilatory assistance and measurement of adequacy using EtCO2, knowing when to oxygenate and when to ventilate, discussing the cellular metabolism through oxygenation, and being able to use CPAP. First, we'll look at some mechanics of breathing. Contraction of the external intercostal muscles elevates the ribs and the sternum. Contraction of the diaphragm is going to move, the diaphragm is going to move downward. Air pressure lowers in the lungs. This negative pressure is what draws air into the lungs. External intercostal muscles will then relax. The diaphragm relaxes. Ribs and sternum will return to a resting position. Pressure increases in the lungs and the air is then exhaled. This is demonstrated by these diagrams, which show how the inhalation and exhalation will actually work. Respiratory physiology. Primary function of the respiratory system is going to be to provide oxygen for cells in the body and to eliminate carbon dioxide and waste that the cells produce. The exchange of gases occur at the alveolar level. Oxygen will diffuse into the cells from the alveoli, and carbon dioxide diffuses into the alveoli from the cells across pressure gradients. This demonstrates that gas exchange between the alveoli and the capillaries. You'll have blood that comes in through the pulmonary artery that is deoxygenated. It's going to move through the capillaries, and the oxygen will diffuse into the red blood cells. Across those pressure gradients, the CO2 and the waste products will then be offloaded, and the blood returns back to the heart through the pulmonary vein. In the alveoli, there is a film of water that coats the alveolar walls. As we exhale, the alveoli will shrink and the water molecules become closer together, creating surface tension. This is what helps keeps the alveoli from collapsing completely. Because the increased surface tension, the alveoli may be vulnerable to collapse if it wasn't for pulmonary surfactant. That's what keeps them open. So what is surfactant? This surfactant decreases surface tension, increases pulmonary compliance, and reduces tendency of alveolar collapse. When we're looking at external and internal respiration, external respiration is the exchange of oxygen and CO2 between the environment and the cells. What we just spoke about at the alveolar level, that would be an example of external respiration. Internal respiration is intracellular. This is going to be the intercellular use of oxygen to create ATP, which gives the cell their energy. This occurs due to diffusion in relation to those partial pressure gradients that we spoke about. So how are oxygen and carbon dioxide carried through the blood? Oxygen is carried in the blood. 98.5% of all oxygen is bound to the hemoglobin. 1.5%, or the remaining portion of oxygen, is dissolved in plasma. Carbon dioxide is transported from the body by the cells. 60% is carried by bicarbonate, 30% carbohemoglobin, which is formed when the CO2 combines with hemoglobin, and 10% is dissolved in plasma. Because almost all the oxygen is bound to hemoglobin, the relationship between partial pressure of oxygen and hemoglobin saturation is very important. Respiratory control. So this is controlled by the rhythmicity center of the medulla. This controls automatic breathing and consists of interacting neurons that fire under inspiration and expiration. The apnostic center is located in the pons, and this stimulates the eye neurons for inspiration. The pneumotaxic center is located in the pons as well, and it inhibits the apnostic center and inspiration. So some factors that will result in increasing respiration, you have chemoreceptors located in the aorta and the carotid arteries, and also in the medulla. The chemoreceptors are stimulated by an increase in CO2 levels more so than by a decrease in oxygen levels. So this is kind of directly tied to like our hypoxic drive, but in a healthy patient, instead of oxygen, we are stimulated to breathe by our level of CO2 that we have in the blood. So as the CO2 levels rise, our brain tells our body that we need to breathe faster and blow off some of this CO2 and get rid of it because we're collecting too much. Or if we don't have enough CO2, if we've blown off too much by hyperventilation or other means, then our brain tells our body to slow our breathing down. And that's kind of how we regulate our respirations. It's going to be very important that we're able to recognize adequate versus inadequate breathing. Okay, first we need to know what's normal before we can realize what is abnormal, right? So with adequate breathing, respiratory rate is within normal limits, which we know to be between 12 and 20 for a healthy adult. Respiration rhythm is going to be regular. Breath sounds are present, clear, and equal. Chest expansion is adequate and equal. And the depth of respirations is also adequate as well. Adequate breathing should be just that. It should be passive. It should be quiet. There should be no adventitious sounds. People should not have to think or concentrate to breathe. So if those things are going on, that's not adequate respirations. If they're having to focus to breathe, that's not adequate respirations, and we're going to need to do something. Tidal volume also comes into play. This is going to be the volume of air a person moves in and out of the respiratory system with each breath. Minute volume is going to be the volume of air moved in and out of the respiratory system within 1 minute. And we get the minute volume by taking our tidal volume and multiplying it by our respiratory rate. That's how we calculate how much volume of air is moved in and out within 1 minute. An example of this, if we have a tidal volume of 500 mLs, which is pretty normal for most average sized adults, 500 mLs per breath times 12 breaths per minute gives us 6,000 mLs per minute, or 6 liters per minute, which is about normal, between 6 to 8 liters per minute. Alveolar ventilation. This is the volume of air reaching the alveoli that participates in gas exchange. This is where we kind of take into consideration not just the tidal volume itself, but we have to consider the dead spaces that are located, in the airways of the trachea, the bronchial branches, that are not basically any areas that are not located in the alveola themselves. So we got to take that dead space into consideration. Inadequate breathing. So, like we were talking about with the normal breathing, how it should be quiet, should be regular, should be effortless. When we're able to recognize there is inadequate breathing, we need to then look at what are some of the causes. So, inadequate breathing is going to cause an inadequate tidal volume, inadequate rate, a combination of inadequate volume and rate. So, shallow breathing, rapid breathing, these are going to be not adequate for tissue perfusion, basically. Inadequate breathing requires immediate management with positive pressure ventilations. So, if we're seeing this, if they're not oxygenating well enough to perfuse the cells, we're going to have to do something, right? And more times than not, it's going to require us to do some positive pressure ventilations. Increase in the rate of ventilation on a patient with inadequate tidal volume may maintain near normal minute volume. However, the alveolar ventilation, where gas exchange occurs, will be inadequate to maintain perfusion. So, with ventilation and circulation, during normal inspiration, or during normal respiration rather, the negative pressure caused by inhalation allows venous blood return to the right side of the heart. During positive pressure ventilation, and this is very important to consider, our normal respiration works on that negative pressure we talked about, with the diaphragm contracting and pulling air in more like a vacuum. When we're doing positive pressure ventilations, we're forcing air in under positive pressure rather than negative. And as that air is forced into the chest, causing an increase in intrathoracic pressure, that increase in pressure impedes venous return to the right side of the heart. When we start talking about positive ventilation and continuous positive airway pressures with CPAP, you'll notice that contraindication in CPAP is going to be a low blood pressure, because CPAP will lower your blood pressure, and this is why. CPAP will cause an increase in thoracic pressure. That increase decreases the venous return to the right side of the heart through the vena cava, and that will cause a drop in blood pressure. So if they already have a low blood pressure, we don't want to drop it even further, basically. So, recognizing respiratory distress versus respiratory failure. Respiratory conditions are dynamic. Minor respiratory distress to they can go from minor respiratory distress to respiratory arrest. Acute, chronic, or chronic with acute exacerbation. Signs and symptoms are dynamic as well, and may change over time depending on the state of the disease process. So many patients with respiratory disease only require comfort measures. It is important to understand when to intervene, when intervention is required in order to improve patient's condition. Basically, for your COPD patients, some of them may not always have SpO2 of 98%. They may It may be normal for them because of the disease process to be having an oxygen saturation of 90% or 92%, 94%. They may live at that lower level. So the goal is no longer to try to get them back up to 100%. We're going to, whatever our interventions may be, whether it's an increase in their nasal cannula rate from 2 to 4, or a simple mask, or breathing treatments, whatever the case may be, we're treating the patient and their degree of respiratory distress, not exactly treating the numbers. We're not necessarily trying to get them back up to 100%. That just may not be possible in that population. So that's important to take into consideration. These signs and symptoms are very dynamic. They change over time. As the disease progresses, their normal may not be normal for everybody. So with respiratory distress, we will have, this is, first off, it's a symptom that patients are going to be experiencing, and then we got the different degrees of respiratory distress. But additional symptoms of respiratory distress are going to come along with agitation, anxiety, restlessness, accessory muscle use, nasal flaring, tachycardias. These are going to be along with, them having a hard time breathing, basically. With the anxiety and agitation, the brain itself is going to be very sensitive to the levels of oxygen, glucose, and blood, that's carrying those things. So when we have a decrease in our oxygen levels, we're going to have a decrease in the way our brain is able to function, right? So that's why you'll start seeing anxiety, agitation, altered mental status. The brain's very sensitive to those things. So as the respiratory distress goes on, they may become more and more agitated because their brain's just not getting enough oxygen, okay? So knowing when we're going from respiratory distress to failure is going to be very important. So basically, respiratory distress, they're not breathing well. They're having those signs and symptoms of, the tachycardia and the increased respirations and the agitation, the anxiety, just from not being able to breathe well. But when we start crossing over to respiratory failure, that's when we have inadequate gas exchange at the alveolar level, okay? So basically, they're not getting that gas exchange. We start going into failure, and bad things start happening. There's two types of respiratory failure. You got type 1 and type 2. Type 1 is going to be hypoxic from low oxygen. Type 2 is going to be hypercapnic from an increase in CO2, or basically they're not able to get rid of the CO2, and that gas starts building up in the bloodstream. So with hypoxic, blood gas and pulse oximeter, PaO2 or SpAO2 are decreased. So they're hypoxic, they're not getting enough oxygen. The cells are not getting enough oxygen as a whole. With type 2, patient is unable to get rid of that CO2, and their EtCO2 is going to be elevated. We must be able to recognize the transition of a respiratory disease from distress to failure. This, you'll start having a marked deterioration of mental status change. Before, with distress, you got anxiety and agitation. Now they're going to start being more confused. They may have a loss of gag reflex. You'll see excessive accessory muscle use, head bobbing, grunting, nasal flaring, decrease in SpO2, cyanosis, hypercarbia. All right, so when you start seeing these signs and symptoms, we're no longer in distress. They have gone into failure. They are no longer able to maintain their own airway a lot of times. Their respiratory drive it's failing. So we always have to intervene at this point. During respiratory distress, the body may be able to compensate on its own with just minimal intervention from us, like maybe just giving them a little bit of oxygen or increasing their nasal cannula, maybe doing some breathing treatments, that sort of thing. But when it comes to failure, now we're going to have to get a lot more aggressive. We may have to ventilate the patient. We may have to do some adjuncts like oral pharyngeal airways, nasal pharyngeal airways. We got to maintain an open and patent airway that the patient may not be able to do by themselves. Oxygenation versus ventilation. Oxygenation is the addition of oxygen to the body. Ventilation exchanges air between the lungs and the atmosphere so that oxygen can be absorbed and carbon dioxide can be removed. So if you hyperventilate with room air, you will lower arterial carbon dioxide content significantly. But if your oxygen levels won't change much at all at that point. On the other hand, if you breathe a high concentration of oxygen but do not increase or decrease your respiratory rate, the arterial oxygen content will greatly increase, but the PCO2 will not change. So you got to have those two working together for the exchange. Hypoventilation is a common cause of hypoxia. We see that like with narcotic overdose. Narcotics kind of knock out their respiratory drive and they don't breathe as quickly, or they slow the respirations down. So hypoventilation, and because of that, they're not getting enough oxygen, so you start seeing hypoxia right along with it. When breathing room air, CO2 takes up space in the alveoli, leaving less room for CO2 because of inadequate respirations or inadequate ventilation. AHA guidelines now recommends patients with suspected acute coronary syndrome or stroke not to receive oxygen unless SpO2 is less than 94% on room air. If pulse oximeter is unreliable or not available, oxygen should be administered. So if you're not sure, administer oxygen. Or if they are presenting with shortness of breath, if they're presenting with dyspnea, has any signs and symptoms of shock or heart failure, then we're going to give oxygen. Basically, the point they're trying to get to is before it was always everybody got high flow O2. You know, if you're having chest pain, if you think you're having a heart attack, you got high flow O2, non-rebreather, 15 liters per minute. Science has determined that's not always the best case scenario. Because oxygen is a drug, and at least how we give oxygen with 100% medical grade oxygen causes different changes in the body, just like any other drug. So oxygen at high concentrations can actually cause vasoconstriction, which in the case of acute coronary syndrome can cause more damage than what you're helping them. So because of those studies, we've decided high flow O2 at 15 liters is not always a good thing. So they changed their guidelines a few years ago to where now they're not going to receive oxygen unless these things are present. Now, the other thing that I will add is if your patient is having shortness of breath, or even if they don't look like they're in distress, but they say, hey, I can't breathe, never withhold oxygen from somebody who thinks they need it or who you think needs it, okay? So that may mean that instead of doing 15 liters non-rebreather, we're just going to do a nasal cannula at 4 liters per minute or 2 liters per minute. So we're not ever going to withhold it if they need it, or if they even think they need it. We're going to give them at least a little bit. Oxygenation of chest pain and stroke patients. If you need to do it, like I said, we're going to start out at 2 liters per minute nasal cannula for anybody who complains of shortness of breath, even if they don't look like they're having signs shortness of breath. If they say, hey, I can't breathe, we're putting them on oxygen. Or if they're experiencing signs and symptoms of shock, they're getting oxygen. If they are experiencing heart failure, have an SpO2 of less than 94% on room air, these patients are getting at least a nasal cannula, and we'll titrate the oxygen to be able to maintain SpO2 of at least 94%, right? So like I said earlier, the goal is no longer to get them to 100%. We need to get them perfusion. We need to get them enough oxygen to be able to do that, which is 94% usually does it. Tissue damage may increase when you have high concentrations of oxygen in acute coronary syndromes and stroke. Basically what I was talking about earlier. To get a little bit deeper as to why, you got those high concentration of oxygen, which releases free radicals. Therefore, it is no longer recommended. These free radicals are going to be byproducts of metabolism. They're toxic to neighboring cells. It destroys their membranes, causes increased local tissue damage. So they're bad, right? Reintroducing high concentration of oxygen to the cells that have been functioning anaerobically, which is, aerobic metabolism is with oxygen. Anaerobic metabolism is going to be when the cell switches from metabolizing with oxygen to without, starts using different components for cellular energy, right? So it switches to anaerobic, which increases the production of free radicals, causing cell membrane damage and tissue death. So delivering high concentration of oxygen in acute coronary syndrome and stroke patients may be more harmful than keeping the patient on room air. So for these reasons, we're no longer shooting for 100%. No one's getting the high flow O2 at 15 liters a minute non-rebreather. We're going to start them out with 2 liters nasal cannula. It's important to know and to be able to do proper ventilation with your patients. Excessive ventilation will decrease that cardiac output because of the increased pressures, like we were talking earlier. It will decrease the return to the heart, which decreases your cardiac output and drops your blood pressure. Excessive ventilation also decreases vital organ perfusion. So because of this, we want to be very conscious about how we're ventilating, how aggressive we're being, and making sure we're ventilating at a adequate rate and volume that is not going to be harmful to the patient, right? Artificial ventilation rates greater than 12 times per minute results in poor patient outcomes. So Even though our normal respirations of an adult should be between 12 and 20, that doesn't mean we're going to be ventilating these patients at 20 and 30 breaths per minute. We're not hyperventilating. We're not going to be excessive with our ventilations. 12 breaths per minute is usually adequate for tissue perfusion in these patients. So in doing this, we need to be able to master the use of that BVM, right? Indications on when to use it. It's going to be respiratory failure or failure. That's when they have failure to ventilate or failure to oxygenate. Contraindications would be a complete airway obstruction. So if you don't have good bag compliance, if you can't get oxygen in, if you can't, if the air is not going anywhere when you squeeze it, you need to be concerned that you got a complete airway obstruction. And that's going to have to be dealt with before BVM ventilations can even begin or continue. Positioning. Sometimes it helps to place towels under the patient's head to position the ear level with the sternal notch, and then extend the patient's head slightly. That's going to open that airway up and keep it from being kinked like you see in that lower picture. If we can open that airway up, it's much easier to ventilate these patients. So you want to open the airway via either the head tilt chin lift or jaw thrust, depending on medical versus trauma. If there's ever a concern with C-spine, even with a fall patient, we may want to use the jaw thrust to protect C-spine. Place a simple airway adjunct. Position the mask. Use correctly sized mask for a good seal. Good seal is going to be very important. One of the most common things we see is gentlemen with beards. We're not able to get a good seal with the beard. We'll talk about that on our skills day, how a couple tips and tricks we can use to get a better seal when we got facial hair and things. Hold the mask in place using the EC technique or the C3 technique. You can use 2 rescuers, which is going to help you get a better seal. Ventilate the patient. Give 1 breath over 1 second, 1 full squeeze, watching the chest rise and fall. We don't need to squeeze it any harder than just enough to see the chest rise and fall. Do not over squeeze. Ventilate 10 to 12 breaths per minute, providing adequate tidal volume. Monitor for air leaks. Make sure we're getting a good seal there, and be cognizant of gastric inflation. So, unless you have a paramedic that has directly intubated this patient with ET tube, all of our adjuncts, even with the eye gels, they're still going to produce a certain amount of gastric inflation or cause some gastric distension. We need to be aware of that, because the more we ventilate, the harder we ventilate, the more at risk we are of gastric inflation, and eventually that stuff's going to come up out of there, and there's possible risk for aspiration. So we got to be careful of that. So some pearls of BVM use: lift the mandible to the mask rather than push the mask down. An adequate seal can be made easier with a mask that is too large compared to one that is too small. Leave dentures in place when possible. If they're not staying in very well, or if you feel like they will be a airway hazard, cause an obstruction, then we want to take them out. Otherwise, we can leave them in place, because that will fill out the cheeks a little bit, the gums, and give you a little bit better seal. If facial hair is making obtaining a seal difficult, you can use water-soluble lubricant over the facial hair to improve mask to face contact. The best way to prevent aspiration is good technique. Capnography. This is our ventilation vital sign. Capnography is becoming more and more better accessible and available, and more squads are using it, and I absolutely love it. It's a great tool. It's a great ventilation vital sign. So this provides breath-to-breath ventilation data. We can see real-time information about the respiratory efforts. It can help us determine the causes of respiratory distress, whether there's bronchospasms going on or something else. Provides real-time feedback on how well treatment is working. Remember, anytime we do an intervention, we want to reassess. So this gives us that feedback and lets us know if our treatments are working or not. Provides confirmation of ET tube placement and can help determine shock. So certain shock states are going to show us a certain CO2 levels. EtCO2 represents the amount of CO2 in exhaled air. What's normal is usually 35 to 45 millimeters mercury. The capnography measures and displays respiratory rates. Changes in respiratory rate are displayed immediately in the waveform on the EtCO2 monitor. The relationship between CO2 and respiratory rate, excuse me, if you have an increase in respiratory rate, this will equal a decrease in CO2 and show up as hyperventilation on the waveform, and that's usually gives you an output less than EtCO2 of 35. This will give you a respiratory alkalosis because we're blowing off too much CO2. Remember, CO2 is kind of it's a kind of a weak acid, so it will have an effect on our acid-base balances, acidosis or alkalosis. So if we don't have enough of that acid, we have an alkalotic state, right? So on the flip side of that, if we have a decrease in respiratory rate, this will give us an increase of CO2 and also hypoventilation, and we will have EtCO2 levels greater than 45, which will equal respiratory acidosis once we go above 45. So interpreting EtCO2 and capnography waveform, normal waveform of the respiratory cycle is similar to like an ECG tracing. The height shows the amount of the CO2. The length depicts time. Waveforms on the screen and printout may differ in duration, so there may be some distortion there. On-screen waveform capnography is considered or is condensed to provide adequate information in a 4-second view. So we're seeing 4 seconds at a time. Printouts are in real time, so that's why the heights may look a little bit shorter, they may be a little bit stretched out. It's just a change in your views. Capnography detects only CO2 from ventilation. So if it's present, that's where it's coming from. No CO2 present is present during inspiration. So baseline is normally 0. Phase 1 is your respiratory baseline. Like we said, it's usually 0. Phase 2 is the expiratory upstroke. Phase 3 is the expiratory plateau. CO2, EtCO2 is the peak level and the numeric reading displayed. And then phase 4 is your inspiratory downstroke. And there you see it. You got your baseline at 1. When you start to exhale, that's phase 2. The plateau during exhalation is phase 3, and your EtCO2 number is going to be your peak expiratory exhaled CO2. That's going to be at the end of phase 3. And then when you start to inhale again, that's going to be phase 4, or in this one it's phase 0. That brings you back to baseline as you inhale and your numbers go back down. So, EtCO2 versus pulse oximetry. I tend to lean more towards EtCO2 because, as we all know, you can get inadequate readings from pulse oximetry. EtCO2 is usually a little bit more accurate when it comes to that. So EtCO2 assesses ventilation, whereas pulse oximetry assesses oxygenation. EtCO2 will show immediate change in ventilation status, whereas pulse oximetry will be delayed in showing decreased oxygen. It takes time for those changes to happen. EtCO2 does not provide false or inadequate readings from factors such as methamoglobin, poor perfusion, movement, or even nail polish. So as we all know, we can get, those are all things that can affect your pulse oximetry readings. Even fluorescent lighting and cold weather can affect your pulse oximetry readouts. So capnography does have some non-intubated applications. It's pretty versatile, really, even on the BLS side of things. I absolutely love it. For non-intubated patients, we can use it to see bronchospasms that would be present in asthma attacks. We can see hypoventilation that would be present in narcotic overdoses. We can also use it to determine levels of shock and circulatory compromise and hyperventilation syndromes. Capnography. So with a bronchospasm, like I said, you'll see this in asthma, COPD, allergic reactions. You'll see this characteristic shark fin with or without a prolonged expiration. Management, we see these. Of course, we're going to be treating the patient. They'll likely be in respiratory distress of some degree. They may be tachypnic. They may have a lot of wheezing. It's just very characteristic of a bronchospasm. And our treatment is going to be bronchodilators. We need to open them back up and relieve that bronchospasm. Exertion exhalations. Elevated CO2 levels should stimulate faster respiration. No effort is needed to exhale CO2. Like I said earlier, it's more passive, right? In COPD, asthma, and pneumonia patients, must exert themselves to exhale and release trapped CO2. You will hear the term air trapping a lot when you hear certain providers talking about COPD patients. Patients with these conditions may be inhaling enough oxygen and to maintain a normal SpO2. However, they are struggling to remove the CO2 levels. So that's why they call it air trapping, is they have a hard time getting it out. They can get air in, but have a hard time getting it out. These patients are not effectively eliminating their CO2 and may be progressing to respiratory failure from hypercarbia and fatigue, not necessarily hypoxia or lack of oxygen. when we're looking at hypoventilation, so we'll have a prolonged waveform. Their baseline CO2 is going to be 0, but as their respirations slow down, again, they're not eliminating enough CO2, so it starts to build up, and you can see that and watch that trend in live time or in real time on the monitor itself. You'll start to see those CO2 levels rise. The height of your waveform will start getting higher and higher. So management for these patients, if they're not breathing fast enough, like with narcotic overdose, we may need to assist their ventilations or intubate them or give them a little bit of Narcan or all the above, right? Shock and circulatory compromise. Capnography has a ventilatory and a circulatory component. Low end-tidal CO2 and other associated signs of shock indicates poor systemic perfusion. Cannot stress that enough. It's not utilized enough. If you have a patient with a low EtCO2 and other signs of poor perfusion like tachycardia, tachypnea, low blood pressures, this will kind of give you an indication of the state of shock they're in, how severe a shock they are in. You could even use it for septic shock. You got a source of infection, they're tachycardic, their blood pressure is low, and I always like to put them on end-tidal CO2 and take a couple measurements and see, well, if they got a end-tidal of say below 30, maybe it's 28 or something like that, then I know that they're in severe septic shock, right? So it's a great tool. Hyperventilation syndrome. You'll have shortened waveforms. Your baseline is again at 0, but the EtCO2 is going to trend down less than 35. Management is going to be, if they're conscious, to utilize the numbers to have the patient slow their respirations. You'll see this in people who are hyperventilating or having panic attacks, anxiety. They may just be, breathing too fast, and you just need to coach them a little bit. Be like, hey, I need you to, concentrate, listen to me, in through your nose, out through your mouth, nice and slow. Let's slow these respirations down because you're breathing a little bit too fast, okay? And you could utilize the numbers on the monitor and be like, hey, this is where you're at. I need you to get these numbers down, around below 20. And that will give them something to focus on. They'll watch those numbers and they'll be able to slow the respirations down. And sometimes that's all it takes. Hyperventilation exceptions would be if your end-tidal is high with tachypnea. So if you got a high end-tidal and they're breathing too fast, we may want to just kind of let that ride and let them continue, because that's the body's way of compensating, right? So let's let them blow off some of that end-tidal CO2. But if they're tachypnic and they have a low CO2, then we're going to have to step in. But if it's high CO2 with tachypnea, then we may let them continue to blow that off and let their body compensate. Other situations this might happen would be severe metabolic acidosis. That's going to be DKA, sepsis, acute renal failure, tricyclic overdoses, antidepressants. Those states, that's going to be the body's way of compensating. So, we're going to help it compensate as much as we can, but that doesn't necessarily mean we need to slow those respirations down back to normal just yet. Its respirations are increased and EtCO2 is high, consider previous diagnosis and treat accordingly. Elevated respirations and high CO2 is not normal. So don't think that it is, but that's the body's way of compensating, right? If you got diabetic ketoacidosis, you're going to have high blood sugar levels. You're going to see Kussmaul's respirations. They're going to be very deep, very rapid, very fast, right? But if you think about it a little bit further than that, why are they breathing that fast? Their body's in a state of acidosis, right there in the diagnosis, right? Diabetic ketoacidosis. So when the body gets to a state of acidosis, there's several ways that it can compensate, or will have buffer systems, like the renal system and the respiratory system are our buffer systems for our acid-base balances. So if the body says we got too much, we need to get rid of it, they're going to get rid of it by excreting it through the urine or by trying to blow it off with the lungs. So we may help the body compensate, but no, it's not normal. Intubated applications for capnography. It's a great tool, kind of the gold standard nowadays for verification. The number one way, of course, is going to, we see it go through the vocal cords, right? But beyond that, and that's the medic's going to be the only one looking at those vocal cords. Beyond that, we're going to be listening to lung sounds, watching chest rise and fall, and we can do capnography. This is going to be even better than the CO2 detectors we put on there, which are qualitative. It tells you if there is something present, which is, in this case is going to be CO2. It tells you if there's CO2 present, but it doesn't tell you how much. Capnography is quantitative. It will actually let you calculate or give you a calculation of how much is actually there. Also, your colorimetric devices, your CO2 detectors they do come with inaccuracies if they've been contaminated with body fluids. So that's always something to consider as well. Other applications, we can use it for ET tube surveillance during patient movement and transport. We can use it to look at CPR efficiency and whether or not we have return of spontaneous circulation. And it's also a very good survival predictor when doing CPR. So we can basically use it to dictate our treatments during a cardiac arrest. So, ET tube confirmation. This is going to be an esophageal intubation, with which, as you know, a ET tube goes into trachea. That's the trachea leads to the lungs. But if we miss and it ends up in the esophagus, we will not have a readout. We will have an absence of CO2 detected, and we will have an absence of a waveform. It will be flat. So that tells us this intubation is no good, and we need to remove it, ventilate the patient again, oxygenate the patient again, and then have the paramedic try to re-intubate. Right main stem intubation. So sometimes you're in the trachea, you're in the lungs, but you've went too deep. And the way the lungs are, at the bifurcation of the carina, it's much easier for that tube to go down the right side than the left side. So if they go too deep, it's almost always going to be a right main stem intubation. So when we have that, we'll have waveform that represents differential ventilation of two lungs. So you'll actually see this little cleft in the waveform itself because you're getting air coming from two different sources, and not at the same time. So the transition phase of gas escaping from the left lung up the tube. So that's the little cleft you'll see, that little transition phase. Management is, if we're seeing that, and another thing we'll have at the same time is good lung sounds on the right, but maybe not much at all on the left. So what we'll do is deflate the cuff, pull back a couple centimeters, reinflate the cuff, and ventilate again. And that should correct the problem. ET surveillance. So once the paramedic has intubated, patient stabilized, we're transporting, we can use capnography for surveillance, mainly for determining whether or not the tube becomes dislodged. So as long as we got good waveform, good end tidal measurements, we're usually pretty good. But once we have a loss of that waveform or a loss of our CO2 reading, then we may have a dislodged ET tube, which again may require replacement. Now, when we're using it for CPR efficiency, we should have a normal looking waveform, with your baseline being at 0. We will have a lower CO2, but it's because with our CPR compressions, we cannot get the gas exchange to happen as well as the heart does itself when it's beating regularly. So we're getting that gas exchange because of the CPR compressions. We're just not getting good enough of gas exchange, right? But we want our numbers to be somewhere between 10 and 15. That's how we know we got good compressions. Okay. And it may even be higher, like when with the Lucas devices, you will absolutely see it higher because the Lucas can do better CPR than any EMT or paramedic that I've ever come across, right? But if you're doing manual compressions, you want it between 10 and 15. If you're starting to drop down, so you can kind of use this to manage the whole cardiac arrest, right? So if you're starting to drop down in numbers, it may be time to switch out your rescuers if you go below 10 and stay there. That means your rescuer is getting fatigued and he's not doing well enough CPR. We need to switch, right? So we can use it to help determine that. ROSC. So we're doing CPR, have been doing CPR for a while. We're doing all the things. The medic's doing the medications and everything's going good. And then all of a sudden, we've been 10, 15 on our ET CO2 readings. And all of a sudden we go from 15 to 40 or 15 to 60. We see a sharp jump like that. We should check for a pulse. We may have actually detected a return of spontaneous circulation and the heart is now beating, right? So check for a pulse, see if we got ROSC. And then we can also use it as a survival predictor. The longer the resuscitation attempt goes, the more is going on there, the less chance that we have of getting them back the longer CPR goes, right? So if you had an initial end-tidal 2 of when you first started greater than 10, so when you first started compressions, you had an ETCO2 almost immediately of 18, you got a higher chance of getting ROSC. If you have a decrease of 25% in your CO2 readings during resuscitation, this is a significant likelihood of mortality. So say if you were doing compressions and you were at 20, just to make the math a little bit easier, you're at 20 and then you have a drop down to 12. That's greater than 25%. It's almost 50% drop. That's going to tell you you've got a much less chance of getting this patient back. Okay, so ETCO2 is a great tool to determine when to cease efforts and when efforts should continue. So you can use it throughout the entire resuscitation attempt, and you can use these guidelines to kind of guide your treatments too. So if you have that significant drop or your end tidal is just staying low, if you're below 10 for, say it drops below 10 and you switched out your compressors and they're doing good compressions, that just is not getting above 10, that's a pretty good indication we're not getting this patient back. We probably, we need to call for cease efforts, right? So it's a great tool when it comes to that. Capnography, if you got a chance, I would pause this video and take a picture of this. This is an excellent guide. Kind of goes over all the waveforms that we were talking about. As far as the different treatments and the different waveforms, this is a very good reference. So I would take a copy of this if you could. CPAP. So continuous positive airway pressure. It's used to provide better oxygenation to patients who are hypoxic. It is not designed to ventilate patients. So they have to be able to do that on themselves, on their own. It reduces the effort that the patient needs to breathe and improves oxygenation and reduces hypercarbia. So it doesn't ventilate the patients, but it just makes it easier for them to ventilate themselves. It can prevent an exacerbation of respiratory distress or failure. So it can keep them from going into failure, can keep them from being needed to be intubated. It applies positive airway pressure above atmospheric pressure during inhalation and provides positive end expiratory pressure, or PEEP, during exhalation. So the positive pressure during inhalation makes it easier for air to get in, and then positive expiratory, or the PEEP, helps keep the alveoli inflated as they exhale, so it keeps it from collapsing so much. Indications: when are we going to use it? Patient needing ventilatory support who is in moderate to severe respiratory distress or early respiratory failure. Patient must be awake, able to obey commands, and have an intact airway reflex, so an intact gag reflex. When are we not going to use it? We're not going to use it if they're not able to maintain their own open airway. That's when we are going to step in and do a oropharyngeal or nasopharyngeal or IGEL. Severe hypotension, less than 90 systolic. Like I said before, because of how that works and the added increased pressure in the chest, it will reduce cardiac output, and you'll see a slight drop in blood pressure. But if their blood pressure is already low, we do not want to complicate things. We can take away their ability to compensate, and they could tank on us. They could crash, right? Respiratory rate less than 8. Okay, I'm sure you've heard less than 8, greater than 28, we need to ventilate. So if they're not breathing no more than 8 times a minute, we should be doing a BVM and not CPAP. The EMS provider needs to deliver assisted artificial ventilations to the patient who exhibit deterioration in mental status because of hypoxia or hypercarbia. So we need to, that's when we need to step in and ventilate the patient. And that is the end of Module 1, Section 1. We will come back and pick up with Module 1, Section 2.